Hi, we're here again for another podcast. Today, I have one of my favorite radiation oncologists, Sean Collins. I may be literally and figuratively his biggest fan. Um, Sean is an expert on treating prostate cancer. And Sean, do me a favor and introduce yourself to everybody.
So I'm Sean Collins. I've been a radiation oncologist for about 20 years at Georgetown, and I love taking care of men with prostate cancer. Brian is too nice to me. I'm one of his biggest fans. I think ACRO has done a great job. Specifically, they've done an amazing job mentoring young radiation oncologists, and I am so happy to be here and talk about the things that I love doing with my patients.
So what we did is to kind of make this a little interactive is Sean put out a few questions on Twitter just to see what you people in the audience and the Twitterverse thought about what would be the best way to treat prostate cancer. And so we put out a couple questions, and I'm going to read the first one, and then we're going to go over the results and kind of figure out what everyone, or have Sean advise us of how to better counsel our patients as they undergo treatment for prostate cancer. All right. So the first question Sean put out there is that you are a U.S. radiation oncologist who treats prostate cancer. Have you ever prescribed Orgovix? And I'm sorry if I call it Orgovix. I got a speech impediment. I'm from Philadelphia.
I agree
Okay.
with you.
And 60% said yes, 34% said no, and 6 said other. Sean, take it over.
So I would say that makes sense to me because I mean I remember when I first so in December 2020, Orgovix was approved by the FDA, and I never would have prescribed it just because like I'm like one of those guys like the like just keep on doing what the standard of care is or what it takes an extra effort on my part to change what I do. Okay, so, but then I had the rep come and talk to me about it, and they're like, "Oh, I mean, I'm worried about all these logistical challenges." But the sales rep actually walked me through these challenges. Her name is Mia. I love her. She's my favorite person to know, and she helped me understand how these medications go through a special pharmacy. And she told me like, hey, by the way, you work for a cancer center. I'm like, yeah, I'm part of the Lombardi Cancer Center. Well, she's like, you have a special oncology pharmacy. By the way, you have special oncology pharmacy technicians that can do all the work for you. All you have to do is order it and they'll do all the logistics. And so she made it really easy for me. And your reps are there to help you go through this process because I agree with you. I don't want my day to day nurse doing all this paperwork. The special pharmacy technicians do most of the paperwork for me. They help the patients navigate the insurance. It's much easier now than it was, in December 2020, because most insurance companies cover it now. In some situations, there's more copays, but the Myovant, which is now Sumitomo, does give financial aid packages, can help you navigate the system, and it's a lot cheaper now than it was in 2020. I think there's huge benefits. Some patients choose to pay a little bit more for pills versus injections because of the quality of life aspect of it. So men, from my experience, and by the way, I'm a 55-year-old guy who's getting frailer every day, really want to have control over their testosterone level. They don't want the doctor dictating, well, you have to have 6 months. They want to take the pill, see how they do, and maybe they'll choose 4 months. From my experience, 4 months is better than 0 months.
It's interesting that you say that because when I was up in Philadelphia area, I had two um, barriers to prescribing Orgovix, and I was trying to prescribe it mainly to the patients who had a high risk of heart disease and trying to take advantage of that benefit with the medication. And part of the challenge was getting the urologist to buy into it, but they didn't provide that much resistance when I explained them what I was doing and why. Where I did, and originally there were some problems with the authorizations, but I was able over time notice that that was something that I could overcome. But having access when I was at in Penn's network, getting access to that special pharmacy so I could write for the medication in the community hospitals I covered was always a challenge.
Hmm.
And now that I'm at, MUSC with the Hollings Cancer Center, it's very easy to have that pharmacist um, handle, figuring out how much out of pocket cost there is with the patient for the medication and getting that taken care of. And it's become a lot easier. But I understand now that, the company has the ability to have an independent special pharmacy. So if you talk to the rep, they'll be able to help you negotiate that and find that uh, um, pharmacy that they have. But I think with those patients with the heart disease, it really does help to put them on Orgovix versus some of the other medications that are out there. Okay, Sean, that was great. Now we're going to do question number 2. Are you ready?
I am ready.
Are you ready?
I am ready.
All right. We got a 73-year-old with unfavorable intermediate risk prostate cancer. You decide to proceed with Orgovix and IMRT. How many months of Orgovix are you going to prescribe?
Well, I like the answer to the question. The answer to the question was 6 months. I think it was something like 70 or 80% of people chose 6 months. So, we're prostate cancer doctors, and our trials are good. They're not as good as the breast cancer doctors. So, the trials have, we haven't looked at 4 months versus 6 months versus 8 months. So 6 months to me is a reasonable compromise. Your testosterone will recover earlier than it would have done if you did the hormone injections. So that number makes sense to me. So I agree with the audience that something like 6 months is the right amount of Orgovix to give.
I agree with you. I think the data says 6. But, when I look at the numbers, 16% did say only 4 months. When do you think there would be an argument to make it for 4 months?
Yeah, it's I don't like I am very patient focused. So I don't know. I think like the patients are better at deciding what they can tolerate and not tolerate. So if a patient takes the Orgovix, has terrible hot flashes, can't get out of bed because they're so tired, maybe that's the guy that should get 4 months. That's better than 0 months. They'll probably get a pretty similar benefit to the 6 months of Orgovix, but clearly the harms in that patient are higher than the arms. I have some patients who start Orgovix, they don't get hot flashes, they don't feel tired, and to me, they're always like, "Hey, can't we do more? Is this going to prolong my survival? Can I do more?" So I like to be very patient focused versus more than just trial focused.
Yeah, I mean, I think sometimes it depends on how well they're tolerating it, you know?
Yep.
All right, question number 3. 65-year-old with intermediate risk prostate cancer. He decides to proceed with ADT and SBRT. The Orgovix rapidly decreases his testosterone to a very low level, less than 20. Any benefit to the rapid, profound castration that you're seeing here or no? Yes or
Yeah.
no?
The things that I would say yes in some circumstances. I think it was 50-50 that question, the answer was 50-50, right?
Correct.
So if you're having bone pain due to diffuse bone metastases, then maybe a rapid reduction will help your bone pain more quickly. You definitely don't want a rise in your testosterone when you have bone pain or when you have an enlarged prostate that's full of cancer, because that could put you into urinary retention. So maybe in the person with a prostate that's very high amount of cancer, maybe a rapid testosterone reduction will help that person. So there's the clinical perspective, and then there's the also like, will a lower testosterone give you a better chance of cure? Okay. So there is a little bit of data out there from the people who failed radiation and have a rising PSA. Dr. Klotz in Toronto did this great study and showed that having a lower testosterone it improves outcomes in people who are on hormonal therapy for a rising PSA after radiation. So there might be some clinical scenarios. We need some smarter radiobiologists out there, someone smarter than me, to find out whether, in terms of radiosensitization, does lowering your testosterone to a lower level improve radiation sensitivity? What we do know is that Orgovix gets you down to a lower testosterone more quickly than Lupron and probably maintains you at a lower testosterone for longer. We've looked at the HERO study, which showed that there was no difference in side effects between Orgovix and Lupron, even though Orgovix had the testosterone that was really low. We looked at the quality of life in that trial, and we couldn't find any differences between Orgovix and Lupron. So I don't think the lower testosterone actually affects side effects of treatment, but I think there are some clinical scenarios where it can improve cancer control rates. What do you think?
So it doesn't harm, but it may help.
Yes.
Okay. And I also like the fact with Orgovix that it turns on off faster.
I
And
love that.
and there may be times when you may have to I don't know what it is, but reverse things quickly. And it just makes me feel that I have more control in managing the patients then, you know?
So I think a lot of 70-year-old guys, unfortunately, are dealing with depression. Okay. So the most common scenario I see this is someone goes on hormonal agents and it just really makes their depression a lot worse than it used to be. And the fact that they can stop the pill and their testosterone can recover quickly, I think is really important to that patient.
Correct. All right. Question number 4. Last question here. You ready?
Yes, I'm ready.
Are there any patients that you would not recommend Orgovix for? Whether it be cognitive decline, polypharmacy, high risk of metastatic disease, or something else?
So, we actually looked at the outcomes in our first 50 patients. And out of the 50, and by the way, I work in Washington, D.C., we have a wide range of patients from different backgrounds, different education. And we checked their testosterones after they were on it. We did adherence questionnaires. And what we found is like 48 out of the 50 had no trouble being adherent to the medication. In my opinion, it's the ideal pill for giving hormonal therapy because it has a half-life of roughly 24 hours. And you can miss it a couple of days. Like let's say you go to Charleston for the weekend and you forget your pills. If you go to visit Brian in Charleston and you forget your pills, you can actually, if you miss it for 2 days, your testosterone's not going to recover. You have to miss it for 7 days.
Correct.
So
That's a key thing. That's a
the
great question if they ever put it on the boards,
Yeah.
is that you can miss it for 7 days and your levels would still be suppressed.
Best. So to me, I think it's the ideal medication pill-wise for giving it. But there are some patients, I try my best. I have great nurses. And still, sometimes there's language barriers. Sometimes people, they're taking 10 other pills. So there was 2 patients that had trouble being compliant. And I just think you have to be aware in your clinic that when you're doing this, those 2, in hindsight, maybe those 2 patients I should have done Lupron injections but this is why you do research, because to me, doing this research made me a better doctor.
Good answer. All right. So that's all we have today. I'm not missing a 5th question, are we?
Do we miss any 5th questions?
I do have one for you.
Yep.
You ready?
Yep.
In the post-op setting, we give like 6 months of androgen deprivation therapy. But what if it's someone like with a Gleason 9 or node positive disease or someone like that? How long hormone therapy would you administer?
Yeah. It's the unfortunately, I think Europe in general and the UK specifically are way ahead of us on these questions. And a recent study has shown that maybe longer course hormonal therapy for those higher risk biochemically recurrent patients is a benefit. Usually for that Gleason 9 people, I'm usually considering doing more like 18 months of hormonal therapy. By the way, I'm a team player. And when people are getting long-term hormonal therapy, I like to work with our medical oncologist. My favorite doctor in the world, not you, Brian, unfortunately, is Nancy Dawson. And we work together on these patients and we decide which patients really need the longer course hormonal therapy versus the shorter course hormonal therapy. She loves Orgovix. She uses it all the time. And sometimes even for some of these patients, she might even add in things like enzalutamide with the Orgovix. So it's actually great working in a community where you can learn from your fellow colleagues and do the best care possible for patients.
All right. Well, I hope to have you down here in South Carolina soon.
I'm looking
Um,
forward to it, man.
but on that, I want to say thank you so much for your time today. And I hope to see you soon, either at Astro or here in Charleston.
I want to thank you for the great work you're doing with these podcasts because you're teaching the community. Not everybody can go to a course at Astro, or ASCO. I think your podcasts really bring information to the community. So thank you for everything you do.
Hey, stay safe.
You too, man.